patients on T4 replacement were still sick with hypothyroid symptoms. They had a high incidence. They were matched with people not on T4 replacement. They had a higher incidence of 5 potentially fatal diseases associated with hypothyroidism, and they used more drugs to control their symptoms. That study showed that T4 replacement in 50% of the cases is ineffective. But just consider this in view of that study finding. The patients go to their doctors fairly often, and the doctors always order a TSH and a T3 and T4 level, which the same corporations own that own the TSH tests and sell them to laboratories. So there's a money-making hit there. Well, high cholesterol, just for example, used to be diagnostic of hypothyroidism. And in my probably 23 years of work in this field, never have I seen a single patient with a high cholesterol and LDL, supposedly bad cholesterol, not a single patient for whom those blood levels didn't fall down into what used to be called the normal range, the reference range, when we treated the patients effectively with thyroid hormones. The number one selling drugs in the United States now, and possibly the world, is the statin drugs that lower cholesterol down into the reference range. And some of the same corporations that own, like Synthroid, or the brand of T4 used in Australia, and own the TSH assays, the T3 and T4 tests, also own statin drugs. If the patent is off of thyroid medications, if people were treated with thyroid medication, those companies would lose billions in revenue. The statin drugs are patented. And so it's almost as though boardroom executives sit and calculate how to keep people's cholesterol levels high enough so they'll have to be put on statin medications to lower their cholesterol, and that brings in billions of dollars in revenue. Now, it may sound conspiratorial, but I think it's the truth.
Yeah, absolutely, and I see it all the time in clinic as well. You see the high cholesterol, you see the hypothyroid symptoms, and this is older medicine, isn't it? It's like the Broda Barnes with the basal metabolic temperature test. These were markers of a hypothyroid problem, and nowadays, because we have more scientific tests, we ignore those simple things that were often much more accurate.
Right. Right.
Yes. And you said that the use of T4 is one of the worst disasters in modern medicine, and I suppose alongside of that, the statins also come in as one of the worst disasters, but they're all interrelated.
Yeah, they are. They are. Yeah, and I'm convinced that practically every patient who has elevated cholesterol and LDL could get them into down in the reference range by first starting with diet and acceptable level of physical fitness and nutritional supplements, and if need be, thyroid hormone.
So if T4 is not effective in most patients, then what type of thyroid hormone do you use in your protocols for helping people get well?
Well, if the patient is hypothyroid, and we have a confirmed thyroid hormone deficiency, or good reason to think that the patient is hypothyroid, we use a T4, T3 product, and there are a lot on the market. Armor Thyroid is, most people have heard of that. That's the oldest one on the market, the most stable and the least expensive. But there's
yes, in Australia, it's called natural thyroid replacement in Australia.
Oh, okay, natural thyroid replacement. And it's all desiccated thyroid,
yes.
Except for Thyrolar, which is synthetic, and some patients like taking an animal product, and Thyrolar is already there. If the patient appears to be thyroid hormone resistant, we use those patients of ours use plain T3. And the reason for that was that in every study that's ever been done, only dosages of T3 that are larger than what the body normally produces are necessary to override the resistance and get the patient well.
Yeah, can you tell us a little bit more about thyroid hormone resistance? Because as I understand it, there are a couple of different indications in fibromyalgia or hypometabolism, and one may be a classic hypothyroid where the thyroid's not producing enough hormone, but the other one is thyroid hormone resistance where the thyroid is producing enough hormone but the cells are not taking it up properly. Can you explain a little bit more about that?
Right. Well, there are laboratory methods for diagnosing thyroid hormone resistance, and one is a very painful procedure where you do a punch biopsy of the skin, and not many patients go for that, but you can take the fibroblasts out of the skin that normally produce the water-binding mucopolysaccharides that give connective tissue turgor. Thyroid hormone usually inhibits the production of those water-binding molecules and keeps them in a normal quantity being synthesized and released into the ground substance of the connective tissues. You can subject patients' fibroblasts to T3 and measure the amount that's necessary to inhibit production of those water-binding molecules. And that's, if it takes an extraordinarily large amount, that's one way of diagnosing cellular resistance to thyroid hormone. But usually what we do clinically is, if our criteria are basically post-treatment criteria, if we assume a patient has hypothyroidism and we treat the patient with a T4, T3 product and get up to around 4 grains or 250 milligrams, and we haven't seen acceptable improvement in the patient, we make the assumption for treatment purposes that the person may be partially resistant, and then we switch the patient over to T3, and through a very careful protocol monitoring for safety and for evidence of improvement, carry the patient to higher and higher dosages. And if the patient ends up on a dosage that would hospitalize most other patients with heart problems, but that patient has no indication whatever of overstimulation, has a very, very high blood level of T3, and the person's hyperthyroid-like symptoms have gone away and the person's functional and symptom-free, we, post-treatment, after the treatment, based on those criteria, diagnose the patient as being thyroid hormone resistant.
Okay, so it's an after-the-fact diagnosis, really, according to how they've responded to different thyroid hormone treatments.
Right, exactly.
So how do you go about diagnosing up front, then, the hypothyroid symptoms? You were talking about the basal metabolic rate and the temperature. How else do you go about diagnosing these problems?
Well, what we do is we actually measure the metabolic rate with an instrument called an indirect calorimeter, and those instruments have been around for some 400 years. They were developed into clinical diagnostic tools about 100 years ago. But what we do is we measure a person's oxygen consumption at rest as close to a vegetative state as possible. And that tells us how much oxygen that person's body is taking in to have enough for cells to exchange oxygen for electrons to remove the energy from the chemical bonds of food breakdown products, such as glucose and fatty acids. And it's amazing how precise that the intake of oxygen is regulated to provide just enough oxygen for what's called oxidative phosphorylation. But if a lot of patients, I work with a lot of patients long distance, and they just don't have access to that procedure. So we don't have them use. You mentioned Dr. Brother Barnes, who developed the basal body temperature test. In the 1940s, he correlated low basal temperatures with low resting metabolic rates, and he established the range of normal, or the reference range we call it now, which is 97.8 to 98.2. And most hypothyroid patients will have a basal temperature below, somewhere around 70 or below.